in the chat. And there it goes. Videos off if you do not wish to be perceived. So raise your hand or post in the chat if you have a question. You can send it to me privately, or if the option is open, to the general chat. And I will hand the floor right on over to Dr. Kovacina.
Thank you. Thank you, everyone. Thank you for the invitation, Alexandra. And I'm so happy to see many familiar faces and names on the screen. Just a quick disclosure. This is the presentation from the OurCare project that was presented at the FMF recently, and also at the Family Medicine Grand Rounds this week. So I'm hoping that this is not too repetitive for the people who are joining for all these events. So today we're going to be talking about the OurCare project, which is a national project on co-designing the future of primary care with patients and the public. As you all know, the public and patients are often left out from the conversations about healthcare reform and healthcare improvement. Most of the time when we have these discussions and conversations, those are with either policymakers, researchers, healthcare professionals, and the patients and public often don't have the place they deserve. So the goal of the OurCare project was really to reach out and to bring together the public and patients, and to discuss with them what their priorities are and what they see important as a value for our system. So what is OurCare? So OurCare is separated in 3 different phases of public consultation. The phase 1 was done in 2022, so last fall, with a national survey that surveyed more than 9,000 people across Canada. In Quebec, it was more than 2,500 people that answered the survey. And it was basically a research survey that was done by the team at the University of Toronto. Principal investigator was Dr. Tara Kieran, who's also the main lead for the OurCare project at the national level. And it was a survey on the patient and public experience of primary care. So how do they experience it? And also asking for some ideas and proposals for improvement. This survey was followed by different panels. So we had across Canada 5 priority panels that brought together around between 30 and 40 people for a kind of group learning sessions online, and also in-person sessions that were more based on deliberation and discussion. And each of these provincial panels produced a report with recommendations from each province. And finally, the 3rd phase was to reach out to the communities that are marginalized and equity deserving, that we knew were underrepresented in these panels and in the survey. So the idea was really to seek the additional priorities and in the additional recommendations that would bonify the overall recommendations and reports. Here I'm just putting the list of different organizations that funded this work. The spread out across Canada was mainly made possible by the contribution of Health Canada. My own disclosure, so regarding this project, I have no conflict of interest or any financial interest in this work. I want to just to let you know that, as I said, the principal investigator was Dr. Tara Kieran, but the work was really done by the group, by the big team that was including myself in Quebec and others in other provinces. And on the more logistic side of organizing these these in-person sessions, organizing the transport and organizing the meetings and writing the report was done by our partners in public engagement. And for the Canadian side was Mass LBP, which is a small organization, but with expertise in public engagement. And in Quebec, it was Institut du Nouveau Monde that was helping the public engagement piece. The project was also done locally and provincially with the advisory group, all kind of stakeholders in primary care were invited and participated. So McGill University was one of them, Department of Family Medicine, then also medical federations, other healthcare professional organizations, the ministry and the government were also involved. So here you can see the Quebec panel. So it's a group of 31 randomly selected people. They were complete strangers to each other, so they really met for the first time online by Zoom, and they had together 3 online sessions when they learned and could be informed about the healthcare system in Quebec and how it works, what is primary care, before they met in person in Montreal at the end of May. So this is basically a photo that was taken on that weekend where they spent about 30 hours together deliberating and producing the report with recommendations. The panel was really selected as close possible to the census data on the demographics of Quebec. So as you can see, was really we tried to respect, gender, age group, ethnicity, geography, and we decided to deliberately overrepresent equity-deserving groups. So with people with income difficulty, newcomers to this country, and people who have no attachment to a healthcare system, so no primary doctor, family doctor, or nurse practitioner following them. So this is just to show you that geographically too, we try to do, we try to really make a group that was representative of the Quebec. With the, we had difficulties, of course, recruiting someone from the northern remote areas, but the province was fairly well represented. This is a group, this is the panel from Ontario, was also representing the province geographically and with over-representations again from the equity-deserving groups. And here we have the panel from BC, Nova Scotia, and Manitoba. Who came to speak to our panelists? So it was a big variety of healthcare experts, different healthcare professionals. We also invited people from clinics or people who work on the ground in the models of care that showed the good results and that there were positive examples for our healthcare system. We also invited policymakers, journalists, and lawyers who had interest in healthcare and policy. Just a little here you can see Dr. Leblanc from St. Mary's Hospital, Mylène Breton from Université de Sherbrooke, Marie-Dominique Beaulieu. So these are all the faces that that were there for our Quebec panel, amongst others. So how did it look like? So the like I said, the panels have a part of their experience that was a learning experience. So really important for us to set the context for them to understand a little bit the organization of the healthcare system, but also to understand the evidence around primary care and the importance of having good primary care. So they were shown actually evidence around that, and also the models that exist elsewhere in the world regarding primary care organization. So once they received that kind of information, they had to work together in deliberation, and they had to come up with the values that the public in the province would accept as base values. They identify the issues that were proper for the context they live in order to produce a priority list and a recommendation list at the end in the form of a report. What our colleagues from the public engagement expertise experts told us were that while we're doing this work, there is this moment where the group might meet what they call a diamond of despair, meaning that they learn about the system and how complex it is and how the problems are there for a long time, and how there was different reforms trying to deal with these problems, and then it would feel like it was just too heavy and too complex for them to solve. But that with deliberation and with trying to put on paper the priorities and different themes, the groups find the solutions and find the recommendations that are meaningful to them. So we saw this happen in all of the panels that we had, the 5 panels, the 5 provinces, and they were able to find the common solution at the end, the recommendations. As you can see here, the values were the ones that we saw a lot of overlap between the provinces. Number one value that came up was, of course, accessibility. And by accessibility, it's not just accessibility, quick access to care. It was really accessibility to primary care, and to have that accessibility to care that's comprehensive, that's continuous, that they have a relationship with someone over time, and that was very important for them. And they really wanted every Canadian to have accessible primary care. A lot of the panels talked about approach that's more preventative and holistic, that it's not disease-based, but that promotes wellness and health. They also talked about accountability in the system, respect for the patients and for families and for public. That was tightly linked also, of course, with equity and to providing care that's equitable for all groups and all communities. They also talked about empowering patients to become in charge of their own health and being able to manage their own health, and that was also tightly linked with access to data and to their own personal record. So as you can see, these values were really common across all provinces. The reports are available online, so you can actually go and look into them. They are really province specific. However, the OurCare is doing now a big organization of these recommendations, and will produce a document that's pan-Canadian and that will serve as a report back to Health Canada to outline the priorities of all Canadians. So I'm going to present you now, like I said, over the 5 panels, we saw a lot of common elements emerge, and we try really to bring these recommendations together by common themes. So I'm going to be presenting to you right now. What I want you to do while I'm presenting the recommendations, really to think of what can we do as a community of scientists, researchers, doctors, what can we do to move forward this public vision for primary care? And we'll come to that a little bit at the end. So the first theme that the panelists were talking about was upstream action, the importance of increasing the proportion of funds to primary care. Also expanding the public coverage to include eye care, dental care, physiotherapy, medication, pharmacare. And it's because the main barrier to all of these elements of primary care was financial. They also wanted to strengthen the links between primary care practitioners and community organizations. And all 5 panels addressed the social determinants of health. Here's the quote for BC. As we see, one of the main frustrations that came over and over again was the lack of access. Public didn't have access to their own medical information or the information of those they were caring for. So as you can see in this quote, we recommend establishing a central medical data platform for clinicians and patients that provides province-wide access to electronic medical records, regardless of database software used in any given location. The goal is to facilitate continuity, portability, comprehensiveness, and efficiency of patient care. So all panels talked about how the databases and the information need to be interconnected and need to be sharing the information. They really wanted patients to be the owners of their own personal medical record. They also talked about virtual care, but virtual care to improve accessibility and equity. So this is a quote from Ontario. We recommend prioritizing the expansion of comprehensive virtual care models to those with mobility challenges and those in rural, remote, and northern areas. The long-term goal, however, is to offer publicly owned and accountable virtual care to all Ontarians. So the virtual care was seen by the public as an excellent tool to improve access to rural, remote areas. It should always be integrated with in-person care. And in order to have these modalities available, they want to make sure that the public infrastructure is there to make the access to affordable and reliable internet possible in those remote and rural areas. They also wanted to improve funding and improving public infrastructure to access points like libraries for those patients who have no internet in their home. And finally, especially for equity deserving communities, they really underline the importance to expand mobile care options, so to bring care closer to their homes. There were many recommendations regarding diversity and inclusion. The panelists really wanted the healthcare professionals to have training in cultural safety, humility, anti-discrimination, and to include community perspectives in curriculum development. They found it was important to have the workforce that's representing the population. So they really wanted to facilitate pathways to primary care professional education for the equity-deserving communities, Indigenous communities, and the Northern communities. They also wanted to indigenize the medical curriculum and integrate Indigenous models of care. The workforce, so the issues and challenges with human resources was one of the main discussions that the panelists had. So they really wanted to accelerate the process for integrating internationally trained primary care professionals in our system. And this doesn't mean going to recruit international trained primary care elsewhere, but to integrate those who are already living in Canada and who can't practice. They wanted to increase the number of family medicine residency spots with special attention to equity-deserving communities. They wanted to work on improving working conditions for healthcare professionals, especially by reducing administrative burden and to focus more on clinical activities. And they also wanted to make sure that the healthcare professionals who are trained and who come from the communities in each province actually can stay there, and they are incentivized to stay in their communities. Here's the quote of Quebec panel. We recommend that the Quebec government, local governments, health and social services institutions, and political parties commit to involving the public in decisions that affect frontline care in order to respect their voice and take their opinions fully into account. There was a big discussion, and one of the major points that the panelists wanted is to involve more the communities and the public in these discussions and decision-making regarding primary care. They wanted to strengthen the community involvement in policy shaping, in delivery, in measurement. They wanted to educate the public. They understood the complexity of the system, and they said that the public would benefit from better education on their rights and also the value of primary care. They want to support patients to navigate the healthcare system. And they also want to participate in measuring and reporting on the primary care system, including impacts of the reforms. In Quebec, the panels even went forward to say how we have to increase investment in primary care research to provide this capacity to do evaluation. Finally, one of the major recommendation was the value of team care based. And by talking about team care, team-based care is really interdisciplinary teams. Here's the quote from Nova Scotia. We recommend increasing the number of community-based collaborative care teams so that every person has access to multidisciplinary care and medical professionals can spend more time with patients and less time on administration. Because in Canada we have team-based care that varies from one province to the other, provinces that had very little team-based care wanted to start implementing team-based care, especially in areas with greatest needs. They want to foster models such as CHE, so community health centers in Ontario, or access centers that are more community governed. They wanted to provinces that had already team-based care advanced, like Ontario or Quebec. They wanted to make changes for Ontario, for example, to amalgamate independent walk-in clinics into team-based models, and in Quebec to give even more autonomy and latitude to non-physicians who are participants in these teams. Finally, one of the boldest recommendations came from BC and Ontario, where they really wanted to model the team primary care teams in primary care to the model of public school system that exists. So here's a quote from Ontario. To ensure that every Ontarian has a primary care home, the government should move towards automatic rostering similar to the public school system. While health teams should be mandated to accept any patient from their catchment area, it is important to maintain an element of patient choice. So like any kid would have a guaranteed spot in a public school system based on their neighborhood, every patient would have a guaranteed spot in a primary care team based on their neighborhood. So these were the recommendations from the priority panels from our phase 2, where we met and deliberated and spent a lot of time with the panels. We also had organized in phase 3 the smaller community tables with marginalized and more vulnerable populations. And those were like a shorter meetings. So it was a one-day in-person meeting with these communities. We didn't have a lot of, I would say it was more difficult to organize these community roundtables because these populations are often very limited in their resources. And by resources, I mean time, because most of the time they are in a lower socioeconomic status. They have to probably work and they cannot just take a day off to discuss healthcare. But we are really happy with the different variety of groups that we were able to gather. And here you can see in different provinces the groups that were involved. So it really was a big range. It was a range from the groups, Indigenous youth, to newcomers, to racialized groups, to LGBT groups, refugee claimants. And these reports, individual reports, are going to be put together as additional report to the OurCare priority panel's recommendations. So this is still under completion. So we don't have really clear recommendations that are produced. However, we can tell you that there was a lot of overlap with the panel recommendations. So we see that these groups also discuss the team-based care, especially those that are community governed and delivered. Also ensuring access to their own records, expanding coverage, reducing financial barriers to care, embracing a holistic approach to care that's more patient-centered, empowering the patients to play an active role in their health, and finally also supporting foreign trained health professionals who already live in Canada to work in Canada. We also found there was a little bit more emphasis in these groups on increasing representations in the healthcare workforce, so to have the workforce that represents better the population, also to address racism, and especially anti-Indigenous and anti-Black racism, to provide language concordant care, and also to respect the self-determination for Indigenous peoples. So when we look at these recommendations from the public and the patients, how do these align with where we are right now in Canada? So coming back from the for the national survey that was done last year, that surveyed about 9,000 adults in Canada, about 22% of respondents responded that they don't have a primary care attachment. They don't have a nurse practitioner or a family doctor who is following them on a regular basis. When we look across Canada, it's even more striking to see the discrepancy between provinces. And provinces like BC, where there's 1 in 4 respondent who said that they don't have a primary doctor, or in Quebec or Atlantic provinces where that number is even higher, closer to 1 in 3. It's really it's a striking image for us to know like how these how much of our population actually is not served and they don't have access to primary care. When we do some adjustments, we see still that there are, as we can say, like factors that are putting people at high risk not to be followed by primary care professionals. So if you're younger, if you are geographically located in one of these provinces, so BC, Quebec, or Atlantic provinces, or if you're in a lower socioeconomic status. When we look at what kind of teams, people who have family doctor and nurse practitioners, what kind of teams they are seen at, a lot of these teams are usually teams with other family doctors or nurse practitioners. Some of them have nurses, but there's very few teams that have other professionals. This is a little bit better in Quebec because we have the model where the GMS actually will have some other professionals. And you can see here that Quebec and Ontario are probably the provinces with a higher, probably presence and models for interdisciplinary work, while other provinces are very low. So this is just to show you that in BC, in Prairies and Atlantic, have probably the lowest rate of exposure to interdisciplinary teams. So we know when it's done right, the interprofessional primary care teams and can increase capacity, improve clinician work life, and improve quality of care. But they need to be implemented also in an appropriate way. So we can see here, for example, in Ontario, which is one of the provinces with the highest number of models of different teams that can exist, that we still, the evidence still shows that we need to really think about where these teams are, and the communities that might need, that have the highest need for these multidisciplinary teams are often those that have no access to these teams. Also, when we look at Canada as a country and how do we spend money in primary care, we see that we are in the countries that spend the least compared to our total budget. So Canada right now is situated at 5.3% of the total health budget that's given in primary care, compared to the average of the OECD countries, which is 8.1%. Also, when we look among the countries with the higher primary care attachment, Canada has the lowest proportion of healthcare spending that is public. There's going to be a study, and this is just a preview, but there's a study that's been published next week in CMAJ, looking at the international comparison with the countries that have the high primary care attachment. And these are, the study look at Norway, Netherlands, UK, and Finland. And we see in these countries that, first of all, there's more spending on primary care. There's more health spending that is public. There's more physicians per capita than in Canada. There are fewer GPs working in focused practices. There are smarter information systems. They're better interconnected. There is automatic or facilitated registration. So for example, just to give you, Norway and Finland have automatic registration for patients. The patients are assigned to a specific clinic or a specific team based on their area where they live. In these countries, we have better organized after-hour care, and so they have very few to no publicly covered walk-ins. Oops. And finally, they have more physician accountability. So what are the trade-offs? So it's very important to think about these when we are thinking about primary care reform and changes that we can make. And what we see right now in Canada is that we have two groups of people. We have the haves and have-nots. So we have the group of patients that we see in our clinics that are registered to a primary care team, that they have a family doctor, they have a nurse practitioner, they have access to these services. And they do have primary care as we, at least, the best optimal primary care they can have. And then we have a part of the population that are the have-nots. So they have zero primary care. They have no primary care at all. And we know that these have-nots are going to increase with time. And the latest estimations is that we are coming soon to a sustainable point where we're going to have more than a third of a population in Canada that might not have an access to the primary care team. And it's something like, can be something close to like 10 million of Canadians have not having the access to primary care. So what can we do? So OurCare, with the experience that we had with the public engagement and the consultation, is thinking about formulating standards that could be for the future of primary care of Canada, standards that could be used maybe by provincial advocacy group for public. And these standards really will turn around these ideas. This is just a draft ideas. So these are not really fully written completely. I'm just sharing with you for the discussion purposes, but it's really that need that we need to spend more on primary care. We need to set the goal of 100% attachment for all Canadians. We need to expand community-governed teams, advanced patient health record, and design the system for equity. We cannot be designing the system for an average Canadian, because then there's going to be a large proportions of Canadians who are going to be left out. We need to design the system for the most vulnerable Canadian to have access to the primary care, and then we know that everyone is going to be covered. Just the last few notes. So what we learned during this process, and me as a family doctor who have no experience in citizen engagement, how to use our power as a citizen. So it's really important to participate, not only by voting, but also by involving ourselves in social actions. We need to invest in relationships with our community, with our global community, with our planet. We need to understand the power that we have as citizens and to use it to the benefit of for the collective benefit. And we need to value this collective. We cannot be just doing and looking towards the outcome that benefit only the few. We need to look towards the collective benefit. I'm going to leave you and end this presentation with this last quote from the Manitoba panel that really illustrates well the process of the OurCare project. So they say, together we feel that the current primary healthcare system honors the system more than it honors and cares for the people it should serve. We truly hope this report is the vehicle through which our voices and ideas for improvement are heard and meaningfully acted upon by decision makers. This panel has modeled the respect, compassion, active listening, and relationship building that needs to be reflected in the primary care system. I'm going to just outline here some media attention that we got. So this is from this week in La Presse. There was an excellent article by Philippe Mercure on the process and on the meaning of the panel that we had in Quebec and the public engagement. And it was put through the lens of one of the participants, Marie-Michel, who was one of our panelists. And so, so thank you for your time. And I'm now opening the table for discussion and questions.
Thank you to everyone for attending. As a reminder, you can raise your hand or send your question to me. We've received one so far about making the presentation available to everybody. That's really a question for the organizers. Will you be able to send out the presentation to everybody?
Of course, yes.
Wonderful. Yes, I see a hand here. First one from Marion Dove, and then Alexandra de Pocamandi will be next.
I'm sorry if I need to turn off my camera. I'm with you. Okay, sorry about that.
Yes.
Neb, thank you so much for this presentation. I was aware of your work and admire it tremendously. I think that this was really an impressive exercise of engagement of citizens across Canada, and kudos to you for the work. One thing that really struck me was the concordance between the provinces in many of the priorities that they selected. I'm wondering if you can talk a little bit, and maybe I missed it in your presentation, but some of the provinces had put accountability at the top of their list or close to the top of their list. And I'm not entirely sure what that means in this context. If you could elaborate on that.
Yes. So I think that accountability piece was including the accountability of the system towards the public and the patients. So it included provider accountability, so the physician accountability, the other healthcare professionals, but also the institutions, the ministry, the decision makers, because all panelists were talking about how the system and how the whole healthcare was not transparent enough, and it was hard to know who was in charge of what and who was accountable for what. So so we put it in that same group of accountability, like as a value, but it was really many different elements of accountability and transparency. Does that answer your question?
Okay. Yeah, go ahead, Alexandra.
Thanks. Thank you for such a great presentation. This is so important work and very powerful work, I would say also. Like, this is really impressive. Maybe for the presentation, rather than sending it, I think we should just specify, we're going to have it posted on our website. And I think the question also asks if you can post it on the website ourcare.ca. So if that's possible, then maybe be in contact with Anya so the recording can actually be shared to you, Neb, and on your website if you want it. But we're going to have it on our website.
Perfect. And just maybe to follow on that, the OurCare.ca website also has a part that's the data website with the national survey results. So if it's very interesting, especially for the research community, to go and look at different questions that were in the survey and how the people answered based also on their province. There are some very interesting findings. We posted, we published few commentaries and op-eds in media on the past year on some of the provincial findings. I can say that what was interesting to see in Quebec is that we were one of the provinces that people reported paying out of pocket the most for primary care consultations, especially in the group that didn't have a primary doctor assigned to them. And it kind of showed how much as an assigned clinic or an assigned primary care team, how it puts extra not only extra stress, but also the cost to the population. So, anyways, there is a lot of granular data that you can actually look in that on that website, and we have a Quebec specific section, so you can really go and look only for our province if you wish so.
So my next question actually is a good link with that, because I was wondering, with all the data that you collected, right, the 9,000 questionnaires that were completed, I guess part of it is available there, but is the data accessible for more complex analysis, or is there a system for other people from outside to actually access the data? And the other question will be, what are the planned next steps for the project with all of this?
Great, thank you. So for the accessing the data really at the low, like the really like raw data, I would refer you then to maybe to contact the OurCare team and the team from a U of T who can probably provide you some information regarding that. But if you want to look at kind of percentages of a population that answered certain questions like in a more kind of legible way, then it's already available. To answer your question regarding the next steps, so I think that, and I'm in Toronto right now at the meeting that's called the Primary Care Crisis, organized by U of T here, and the team, the Upstream Lab, Andrew Pinto, the U of T Department of Family Medicine with Daniel Martin, and the researchers from Ontario and the rest of Canada. And that was one of the main questions, is like, how do we make this into a movement to make sure that eventually all Canadians are going to have access to primary care. And there's a lot of the conclusion actually of what the why and how do we go forward with this is really to use the public voice, and that is what's needed to, I think, create any social movement. I think that if the researchers and the physicians and the organization actually support the public to voice what they're living, to share their stories, I think that's the most powerful tool that we can have to really make change. And so there's a lot of course, coordination and work to be done. But for sure, what we would like to, at least with this project, is to keep those connections with the public members that participated, and a lot of them actually showed interest to pursue some sort of collaboration and to maybe use their stories or to have them showcase the importance of primary care and the importance of the good side of having primary care, but also what happens when you don't have primary care, because a lot of those panelists didn't have access to primary care or family doctor. And so we can really use that as a value, as an important value to the, and I think that we as a clinicians and scientists, we knowing what primary care is, it's a big complex thing, and we always think that it's hard for people to understand the importance of it. But when we speak to our patients and public, for them it's very important, and they understand it, like they lived it. Everyone had contact at some point, either through the family member or themselves, with primary care. And so if there's anything in healthcare that it's close to patients and the public and the population, it's primary care. And so we find that using that public voice and putting them forward actually can be very beneficial. So I would say that there is going to be some sort of movement and development that's building on the public voice, and that's probably going to be something that's going to be happening even at the Canadian level. But anyways, the people who were here from the Quebec, they felt there was a need to start something also locally at the provincial level that could kind of follow in the same vein. But the main goal and the main kind of long-term goal would be really to look forward, having the access for every Canadian to primary care that's of good quality and that's organized according to a standard that we define.
Thanks. And I'm just going to specify for the source of data. I was just thinking this could be a fantastic source of data for our graduate students. So that's why I was asking.
Well, exactly. So you can look up what's available and how you can navigate. And if there's any other needs for accessing other data, you can tell me. Like there's some that are like free text that can be accessed, and that I ask the team to extract for me for Quebec, for example. So that's all accessible and it's open, and they're more than happy to share the results with everyone. Yes, Isabel.
Wonderful. Excellent, you got there.
Fantastic, Neb. I think it's so important what you have done, and with Taha and her team and so on. I'm curious to know how, if you have any comments on how to make interdisciplinary care better functioning, because in our own study on older persons, sometimes they feel like a bit of a fragmentation. You know, they see the family physician, they see the nurse practitioner, the social worker, the pharmacist, and in fact, in the end, they are lost, and the only person they want to see is their family physician, usually, when they are very old. So how do you see that we can better organize care and interdisciplinary care to make sure that it's a coherent whole rather than healthcare professionals working in silo? And my second question, do you think that it would be worth comparing the answers done by older persons versus more younger persons, or if you see any avenue in this?
Thank you, Isabel. Just to answer your last question, the data was not separated by age, so we didn't look at specific age groups, but it's possible because it's collected. So you know, if anyone is interested, you know, from the people who are listening to us now, they can do that. They can go and extract data that's really based on age, and they can look at that. To answer to you, like regarding the teams, so that's like $1 million question, and I think what everyone realized, I think, and in Quebec, I think we have a very good experience, you know, terrain, like all of us who are practicing medicine, is that, you know, we cannot just put people in places and expect them to work together. Okay, so there is a way that that needs to be how that's going to be implemented. I think there is a group called Team Primary Care that's working a lot on this. I think there is a conference coming up in February in Ottawa, Team Primary Care, that's really looking at this, how the interdisciplinary care is actually possible. What are the what are the hurdles, like how we can solve this. There's also a question of like how each professional group, how do we train people to work in primary care. We know that, for example, our nursing colleagues, they have zero training in primary care, and how we can, you know, enhance that, and you know, how can we really make sure that the workforce that we have is actually properly trained and is able to function in a multidisciplinary team. So I don't have an answer for you, but this is a key question for any implementation of team-based care, and that's something that we missed in Quebec with the implementation of different professionals in our GMFs without doing any work on how they can work together efficiently. And this is what happens right now. And so all, like you said, everyone's seeing a doctor first, and then I'm the one referring to the professionals. And so the doctor becomes a point pivot, which it's not an efficient team-based care. Like team-based care should be the patient is seeing someone from the team who's the most appropriate person to see for their problem, and not passing through one physician all the time to get the services. So excellent point. Thank you, Isabel, for bringing it up.
Okay, I don't see any further questions either on text or hand raised, so I'll fill in with one of my own to give folks one last opportunity. We are starting to run out of time though. So my question is, I really love the model based on children in primary school being automatically given a primary care team. That sounds like a good way to think about it. But adults are more mobile than children. They come in and out of provinces, and even in and out of different locations in a province. So I'm wondering how you're all thinking about dealing with a population that is that mobile and doesn't always give notice of moving.
Mm-hmm. So I would say that, you know, we all experience that. Like we have patients that we follow and that they move to another city and they're still coming back to see us as their primary care provider. But the idea is not to necessarily to force people to like change providers. I think there might be models that might be more flexible. The idea is more to assign a new provider based on your geographical area, and there will need to be some sort of public education. We saw in our survey, one of the questions was actually, do you mind switching providers if you change to another city, to someone who's closer to you? And people are not close to that idea. Like, I think everyone wants, you know, you might decide to change the school or not, or to change your dentist or not. Like, I think there is a lot of factors that can influence that. So there needs to be some sort of a personal choice that's available there. But the idea is really to attach you to a team that's community-based, that you actually, you know, you can really consult, and you can use their services in an appropriate way and a more efficient way than when your team is in a different city or very far from you.
Wonderful, thank you. Yeah, I meant more in terms of onboarding people when they enter a new place than trying to force them to stick with a particular physician. But yeah, that makes sense. Are there any other questions, comments, compliments for Dr. Kovacina's generous donation of his time and expertise? Oh, yes, Marian Dove. I see your hand.
Clapping, giving compliments.
Thank you, everyone. Thank you very much for inviting me, and I'm more than happy to keep you informed about the next steps, and possibly, like, you know, in 6 months, give you a little update.
I think that'd be great. Yeah. Thank you for doing this presentation.
Thank you. Have a nice day.
Wonderful. Take care, everybody. More information will be out about the next seminars. Thank you again, Dr. Kovacina.
Bye.
You can stop the recording.